Funding for this talk comes from TrialX, connecting patients to clinical trials.
Good evening and welcome to Cure Talks. I'm Priya Menon, Scientific Media Editor of Cure Talks, joining you from India. And this is Cure Talks' 103rd episode. Today we are talking about multiple myeloma. Before we begin with today's talk details, I would like to take a few minutes to mention about the new study Cure Talks is involved with. The study, called America Walks, is the first mobile app study on walking. The study is sponsored by our sister concern TrialX.com and is led by Dr. Chintan Patel. The purpose of the study is to determine your walking pattern and how much you are actually walking. You can also compare your walking habit with that of your friends and peers in your state as well as in your country. To participate in the study, all you need to do is download the app on your iPhone or your Android phones. The details are available at TrialX.com/AmericaWalksStudy. So let's get America walking. Coming to today's talk, my co-host is myeloma survivor and editor of MyelomaSurvival.com, Gary Peterson. And supporting Gary on the panel is our myeloma panel of Jack Aiello and Cynthia Chmielewski. Welcome to Cure Talks. Clinical trials of new combination therapies are showing promising results and can be game changers in myeloma treatment. Combining standard drugs with monoclonal antibodies, myeloma vaccine combinations, T-cell therapies with stem cell transplants, and more. The myeloma panel is talking to Dr. Saad Usmani on the most relevant combination therapies and new myeloma treatments in the pipeline patients should keep track of. Dr. Usmani is Director of Plasma Cell Disorder Program and Clinical Research in Hematologic Malignancies at the Levine Cancer Institute. Welcome to Cure Talks, Doctor.
Thank you. It's a pleasure to be.
Before I hand over to Gary to introduce Dr. Usmani and begin with the discussion, I would like to remind our audience that we will be addressing questions sent by listeners towards the end of the discussion. If you have a question for Dr. Usmani, you may press 1 on your keypads and let us know, or you can mail your question to me, priya@trialx.com, or post it on our Cure Talks website. With that, it's over to Gary. Gary, you're on air.
Well, thank you so much. I appreciate all that you do, Priya, and the fact that you're probably up late, or early. I can't remember. What is it?
Yeah, it's early. It's like around 2:30 a.m. here.
Yes, so we really do appreciate that. Yeah, you're giving up your sleep for all of us here in the United States, and much later than that for the folks in Europe. But thank you so much for all that you do for us, and we'll be thinking about you this weekend as we celebrate Pat Killingsworth, our dear friend and associate, who will be sorely missed this weekend as we have his myeloma survival school. But obviously it's a sad day for us, but it's great that we have Dr. Saad Usmani here today. And Dr. Saad Usmani is the Clinical Associate Professor of Medicine at UNC Chapel Hill School of Medicine. He is also the director of the Plasma Cell Disorder Program at, I think it's Levin Cancer Institute, Director of Clinical Research in Hematology Malignancies at the Levin Cancer Institute, Carolina's healthcare system. So Dr. Usmani received his medical education at Lahore, Pakistan, and if I'm not sure that's the same as Dr. Asher Janan Khan, who is here in Jacksonville. He completed a residency in internal medicine at Sinai Grace Hospital, Wayne State University in Detroit, Michigan, fellowship in hematology and oncology at the University of Connecticut Health Center in Farmington, Connecticut. Dr. Usmani is a member of the International Myeloma Working Group, the Southwest Oncology Group Myeloma Committee, the American Society of Hematology, the American Society of Clinical Oncology, and the American Society of Bone Marrow Transplantation. He also serves on the ASCO, American Society of Clinical Oncology Scientific Committee on Lymphoma and Plasma Cell Disorders, the ASH Committee on Plasma Cell Neoplasia, and NCI Myeloma Steering Committee. Dr. Usmani is on the Educational Review Board of numerous medical journals, has co-authored more than 70 peer-reviewed research manuscripts and 90 abstracts at national and international meetings. He has also served as the major PI and co-PI for over 35 clinical trials, phase 1 through 3, a specialist in hematology, medical oncology, bone marrow transplantation. Dr. Usmani's clinical and translational research has focused on high-risk multiple myeloma, and for all of us who have multiple myeloma, we recognize that if we can solve the key to high-risk multiple myeloma, we will, in fact, have solved the key to all myeloma. So, Dr. Usmani, thank you so much for all that you do for us, and not only that, all of that which I just talked about. I understand that you were in fact torn between doing this and everything I just said, and being a world-class cricket player. Is that correct?
Thank you so much for the introduction, Gary. And you're right. It was a tough decision, but I was young, and my father, just like any Pakistani or Desi parent, as Priya and I would call it, he showed me the way. He told me otherwise.
Told you the way? Well, we are so thankful that he showed you the way to us, because we certainly appreciate all that you have done and continue to do in myeloma and myeloma research and myeloma care as well. So, Dr. Usmani, we have been blessed by an outpouring of new drugs this year. It's amazing how many new drugs have come just in the myeloma space. We're a 1% disease, and for me, that's amazing that people like yourself would even operate in that area, because there's so many other opportunities out there, but it happens to be one of the most difficult and most promising, and I think for most people just a challenge. And thank you for being there. But what are the drugs, and what are those drugs and the combination of those drugs would you see have the most promise for the future?
Gary, this is truly an exciting time to be a myeloma researcher. Despite our challenges of still understanding and grasping the disease biology, we have been very successful and fortunate in many ways to have the ability to investigate several different mechanisms of actions or drug classes in myeloma today. And I think with these new drug approvals, I think we're still scratching the surface. Even though we have 9 drugs that have been approved in myeloma and 4 last year, we have to appreciate that even though these are newer drugs, for the longest time, almost a decade, all we had in terms of novel therapies was a class of drug called IMiD, or immunomodulatory drugs, and proteasome inhibitors. So what's the most exciting thing in the past 2 or 3 years as a myeloma researcher and early drug development clinical trialist is that we have new drug classes like HDAC inhibitors and then monoclonal antibodies that are targeting specific surface markers and pathways that are being developed. So all of those things are very exciting. The senior myeloma researchers from the 80s, 90s, and even early 2000s, their challenge was trying to move away from conventional chemotherapies, which cause a lot of side effects, and truly move more towards selective therapeutic targets and trying to improve the side effect profile of these drugs. So I think we're very fortunate that we're in an era where we have a lot of these therapies in development, and I'd be happy to elaborate on them based on what you would like to ask me.
Well, I guess what are the there's so many. Well, the 4 new drugs that came up: panobinostat, daratumumab, Ninlaro. What are the combinations of those drugs that you see that have the most promise for the future?
Okay. I think panobinostat, when it was approved by the FDA, it was approved based on its combination with a proteasome inhibitor, bortezomib. And even though it had demonstrated overall survival benefit, we were concerned about the side effect or safety profile, where we saw a lot of GI side effects and increased neurotoxicity effects with that combination. But the bottom line with that combination specifically was that that platform worked for patients. Combining a proteasome inhibitor and IMiD had been for the longest time our mainstay for treatment, but now we had a new platform, which is PI combining with a new class of drugs called HDAC inhibitors. So, in reality, panobinostat will probably partner better with safer or better tolerated proteasome inhibitors. I see for panobinostat, the combination with kyprolis or carfilzomib will likely be better tolerated, and that's probably where we'll find this drug being partnered with. Ninlaro or ixazomib is the first oral proteasome inhibitor that has been approved for patients beyond 1 prior line of treatment in combination with lenalidomide and dexamethasone, and that provides a very good all-oral option for patients where you want to combine an IMiD with a proteasome inhibitor as their line of treatment. Elotuzumab, which is an antibody targeting a surface marker called SLAMF7, which is highly expressed by these plasma cells. That also got FDA approved in a very similar line of treatment. So patients who've had 1 prior line of treatment up to 3 prior lines of treatment. The exciting thing about that combination is that elotuzumab, even though it's an antibody and it needs to be infused, it does not have a lot of side effects. And in patients who are responding, we're seeing sustained responses in a very unique mechanism. So the patient's own immune system is being utilized to suppress the myeloma cells and control the disease, and that's quite exciting. The 4th drug, I believe, daratumumab, is probably the most exciting monoclonal antibody right now by virtue of its single agent activity in patients who have more advanced myeloma, who have had at least 3 prior lines of treatment, or they have become double refractory, which is refractory to lenalidomide as well as to bortezomib, which again have been our mainstay for myeloma therapy for over a decade. The challenges with daratumumab are the longer infusion times, especially during that first cycle of treatment, and infusion-related reactions, which may happen in about half of the patients. But mostly those infusion-related reactions are mild and easily managed by treatments that we would give for allergic reactions to other monoclonal antibodies that we utilize for diseases like lymphoma. Daratumumab is the first monoclonal antibody that actually has single-agent activity in fairly advanced relapse refractory patients. It had a response rate of roughly 31% in a combined analysis on 148 patients. The data were presented at ASH, which would mean that roughly 1 in 3 patients who are receiving this therapy will have benefit. And the exciting thing about that was, you have now a monoclonal antibody that has activity on its own. You have a mechanism of action that has activity on its own. You can combine it with a proteasome inhibitor on its own as well as with an IMiD. So we're moving away from just an IMiD combination with the proteasome inhibitor. We now have these different drug classes, and we can combine these drug classes together, the patients will continue to benefit from these combinations. So it's the overall message that I would like to give. We have all these drugs that are being FDA approved, but the way that we are thinking about these drugs is how do we combine specific drugs in a drug class with another drug in the next drug class, and which patients do we choose to go for certain combinations. That is something that we as myeloma researchers have to work on over the next 5 years.
The checkpoint inhibitors, that's another class of drugs, which is kind of amazing to me, is that we have daratumumab, which is a monoclonal antibody, which is a brand new class of drugs, where we had the IMiDs and the proteasome inhibitors. Then we have daratumumab, which is another class of drugs, and this checkpoint inhibitors is another class of drugs as well. So, what kind of things can you say about that new class, which is the checkpoint inhibitors, which seems to be a very exciting thing for many myeloma researchers?
For sure. I think the checkpoint inhibitors have really changed the landscape of oncology in general. The early data and excitement started from solid oncology research, specifically in metastatic melanoma and metastatic renal cell carcinoma, when drugs like ipilimumab and nivolumab were being evaluated. But now we have drugs like pembrolizumab, which have shown, very unique and significant activity in solids. The reason why I say unique, essentially you're trying to wake up the immune system, which had become tolerant to these cancer cells, and enable the immune system to make clonal T cells to go after cancer cells. Which is very unique, And in a normal person, in a younger person, when our body cells are dividing and making mistakes in division, one of the functions of the immune system is to take out the abnormal cells, and that's one of the functions of the immune system. But over time, as we age and our immune system becomes less competent, the immune system can become tolerant to these cancer cells, and then eventually these cancer cells can start evading the immune system. And what these checkpoint inhibitors are doing is waking the immune system up and activating it to try to counter the cancer cells. So this mechanism of action in general across the board for cancer is very exciting. And we have several clinical trials where we're now evaluating monoclonal antibodies that are targeting the checkpoint inhibitor, checkpoint pathway, and combining them with proteasome inhibitors as well as IMiDs. It's very likely that we will be combining some of the monoclonal antibodies that have single-agent activity with each other. So it's very likely that we may have an anti-CD38 monoclonal antibody being combined with a checkpoint inhibitor in early phase clinical trials. We've been talking, several myeloma researchers have been talking to different companies to come up with a clinical trial, with that concept in mind. And you can imagine, having the advantage with monoclonal antibodies is the safety profile being very favorable. If we can potentially come up with a 2 monoclonal antibody combination that may benefit our patients from the time of diagnosis onwards, and it can keep the disease under check, potentially for a long time. So there is a lot of excitement there.
Well, thank you, Doctor. Of these new combinations and drugs, do you see any which are effective used on patients with high-risk multiple myeloma? And I know that that's one of the things that you're very much involved in is the high-risk multiple myeloma, and that's kind of the area where we, as cancer patients, understand that ultimately we all end up at is no matter how we start, we end up high risk, and if you don't solve high risk, then ultimately we pay the price. So, do you see anything there?
For sure. The way that I would explain this is as follows. We have in the past developed myeloma therapies in a normal plasma cell biology way. So when the proteasome inhibitors were developed, we understood that the proteasome is very important for the plasma cell, a normal plasma cell. And if you shut the proteasome factory down, then you can kill a normal plasma cell. So we took that concept and applied it to malignant plasma cells when we developed the proteasome inhibitors. Then as we started to become more savvy, we started to think of specific pathway-driven therapy. So if you recall, there were FGFR3 inhibitors being evaluated in clinical trials for myeloma. There are AKT inhibitors being evaluated for clinical trials in myeloma. And what that approach is trying to do is go after the biology of the malignant plasma cell. So that's the second category of the way that we are approaching developing treatments for myeloma. Pick out the pathways that are active in specific patients and try to develop a drug that can target that specific pathway in a malignant plasma cell. The unique thing about the monoclonal antibodies, however, is the monoclonal antibodies generally don't care what's going on inside the myeloma cell. They are going to go after what's on the myeloma cell's surface. So if the cell has CD38 overexpression, the monoclonal antibody is going to tag that plasma cell and try to take it out through its 3 or 4 different mechanisms. So the reason why I'm bringing that up is there is a lot of excitement about the activity of monoclonal antibodies in high-risk patients. The reason why high-risk myeloma becomes high-risk is because of the genomic chaos that's going on inside the myeloma cell. And if we are developing strategies that do not care what's happening inside the myeloma cell, but are going to be engaging the bone marrow microenvironment and the immune system to go after the myeloma cell, regardless of whatever pathways are active inside that cell, then that's a very different way of looking at treating a particular disease. So I truly believe that with some of these monoclonal antibodies that are in clinical development, that we will have good, meaningful activity in high-risk disease. We are hoping to partner some of these monoclonal antibodies with available platform drugs for high-risk myeloma patients. The Swog 1211 trial was the first NCI mandated Swog cooperative group run clinical trial that combined elotuzumab for high-risk patients with RVD. That particular trial is now opening 2 new arms, hopefully later this summer, where one of the arms will be KRD and the other will be KRD daratumumab. And what we're hoping to see is meaningful, long-lasting responses and survival outcomes for high-risk patients. Again, with the caveat that with daratumumab, we've already seen patients who have fairly advanced disease with deletion 17p who've been through every known available FDA-approved option, and patients. Some of these patients are doing extremely well for extended periods of time with single-agent monoclonal antibodies.
Well, one of the things that I've noticed, at least in my local IMF support group, is that, like you mentioned, 17p. It seems like Ninlaro was one drug that seemed to be very effective against, that particular chromosomal abnormality. And she had, given the fact that 17p, the average life expectancy for high-risk patients is about 2 years, has consistently been that. She had like 3 or 4 years on just Ninlaro, and then recently went on another clinical trial, which was, I think, ABT 199, and her myeloma is undetectable. So that I thought was amazing.
Yeah, so ABT 199 is another exciting class of drugs. It's a BCL2 inhibitor, with terms, coming back to, I'll try to come to Ninlaro first, and that is a phenomenal response, and the way that most myeloma experts think of Ninlaro is an oral proteasome inhibitor, first in its class, but perhaps in terms of efficacy, it may not be able to overcome the high-risk features of p53 deletion or translocation 414 on its own. It can certainly improve the outcome, but it cannot overcome the poor prognostic features that are conferred by translocation 414. We feel that in terms of its activity, it's very similar to bortezomib because it, again, belongs to the same class. It's structurally very similar, and we do not see it as being more efficacious than bortezomib. So in terms of activity, it's going to be, what we feel is about the same. If we had done a clinical trial looking at RVD versus RD, I think RVD would have fared, comparatively, would have been comparable to IRD in the eventual outcome analysis. But having an oral regimen with better side effect profile to bortezomib is what is the better measure of ixazomib's advantage. It is an oral agent. It causes less neuropathy than bortezomib. We've known that bortezomib can help, or proteasome inhibitor IMiD combination can help improve the outcomes in some TP53 or P53 deleted patients, as well as translocation 414 patients. But we also know that yes, there is some benefit, but the poor prognostic implications aren't overcome. So we still need to do a better job in finding better answers and combinations for high-risk disease. These anecdotal experiences tell you about how heterogeneous the disease is. There are patients who have P53 disease who can actually do extremely well. The percentage of those patients is very low, but there are patients who can have extended survivals with even the standard available therapies.
Well, thank you, Doctor. I just think it's amazing how many and what a team exists in the myeloma space. And I mean the doctors, the researchers, the IMF, the MMRF, and the myeloma advocates, and how you guys have done such a great job in coming up with 1/3 of all cancer drugs for a 1% disease. It's crazy. It's to me it's a myeloma miracle, and I thank you and all the people who contribute to that. We have 9 major drugs prior to this year for multiple myeloma, and now we have 4 more. Basic math, tells me there are 511 possible combinations with 9 drugs, and an astounding 8,191 possible combinations with 13 drugs. How does any specialist navigate this kind of complexity?
The way that I would, I would reiterate some of the messages that I've tried to give early. The way that we are thinking of these drugs is by drug class. So, within the IMiDs we have thalidomide, which which is FDA approved, but doesn't have as much use here in the United States anymore than it does in Europe. Then we have lenalidomide and pomalidomide, each with its own utility in a certain line or setting in myeloma. Then we have the proteasome inhibitors, bortezomib, carfilzomib, and ixazomib. The HDAC inhibitors, we have one drug class. With an anti-CD38, it's daratumumab right now, but isatuximab, which is a Sanofi drug, it's not far behind. With anti-SLAMF7 antibody, we have elotuzumab. The way that we're thinking of combining these drugs again is, for the upfront patients, we still think of patients in a transplant eligible or ineligible way. So we're trying to combine the best therapies to eradicate the disease as much as possible in all patient groups. But to get to that point, we still have to combine these therapies in a disease, in a meaningful way. We cannot do this in a Arkansan total therapy way where we are throwing all these drugs. So we have to be a little thoughtful. And as we think about disease, we also have to think about cost. So the way that we are approaching treatments, we already have this platform of proteasome inhibitors and IMiDs that we have been using along with steroids. We have to think of partnering the best agent that will give us the best response for this class of, for different classes of drugs. For transplant eligible patients, we're thinking of combining monoclonal antibodies with the 3 drug combinations like RVD, or carfilzomib or KRD. For transplant ineligible upfront patients, bortezomib or lenalidomide are being combined with monoclonal antibodies in the upfront setting. The idea is to improve the depth of response and survival outcomes. When patients are relapsing, one of the things that we're looking at is prior treatments received, what kind of responses patients had to those treatments, what kind of side effects they had to those treatments, and what are the disease features at relapse, whether it's a biochemical relapse or a clinical relapse. And it's not a simple decision. Honestly, it is a very personalized decision that has to be made for each patient. One key element that we are starting to grasp now in a better way is that we've been approaching myeloma treatment in a one-size-fits-all way for a long time. But myeloma is biologically a very heterogeneous disease. It's very likely that the 25,000 odd patients that are diagnosed with myeloma every year, they belong to 10 different categories biologically, and it's very likely that each of those biologic categories are going to respond to different drugs in different ways. We have to tease that out so that we can make the best decisions for our patients. So you've rightly said, how does any myeloma specialist navigate this complexity? We are still trying to figure that out. It's not an easy answer.
Well, thank you, doctor. And I often say, to people who write me on, my blog, myelomasurvival.com, that you need a doctor who is right in the mix of it to even attempt to navigate through such a minefield of possibilities. That and I think it was Dr. Palumbo who said that if your doctor doesn't see hundreds of patients with multiple myeloma, that they really aren't in a position to treat the disease because it's that complex.
I agree with Antonio's comments there. The challenge in the United States is not every region has a myeloma-specific program. Eventually, I think we will get there. But for patients who are listening to this show and who are being treated by a local oncologist and you're not close to a myeloma center, it's totally okay to continue your care with your current doctor if you are comfortable, but do seek out an opinion from a myeloma expert who lives close to you, and have them as a backup to look over things. This is something that I keep on stressing. You're absolutely right. The way that the field is changing, you have to have a myeloma expert in your back pocket who can help guide things, especially with subsequent lines of treatment.
Okay. Well, thank you. And that's kind of been my message over time, is that there's a skill set that you obtain after you've been treating hundreds, maybe thousands of myeloma patients that nobody else can duplicate if they only see one or two. Jack Iola, are you there?
I am, Gary. How are you?
Okay. Jack, I'm so sorry to hear about your father. That is so sad. I can't even imagine. I'm just thank you so much for coming and contributing today. I know that you must be having a very, very sad time. So thank you, Jack.
Well, I'm always appreciative of getting to talk to Dr. Usmani, and I hope you're doing well, Doctor. I wanted to follow up on one of the questions and comments that was made about Ninlaro, which is also called Ixazomib for new listeners out there. And it's the newly approved oral proteasome inhibitor, unlike its cousins that are infused, the Carfilzomib or the Velcade. And I'm wondering, Doctor, if you are having patients the use of Ninlaro off-label, such as in induction treatment, first-line treatment, or more likely even in maintenance, where it becomes a much more convenient oral therapy versus the other two that I mentioned. And if in maintenance, are you prescribing it to be used alone or with Revlimid or dexamethasone or both? Can you talk about that?
Sure, Jack. We have, what I can tell you is 2016 has been a challenging year for many patients from the insurance perspective. I've had a lot of challenges trying to get, so that was my first inclination. Now, patients who are receiving bortezomib as either single agent maintenance because they have specific disease features or convenience because they didn't want to be on an oral agent every day. When we try to get Ixazomib, we are getting pushback from the insurance companies. They would only approve it if it's utilized with lenalidomide and for patients with one prior line of treatment. I have been able to get away with 2 patients, but for most of my patients, I've had refusals, and I have been unable to get this for the upfront setting at all. I think it would be a really cool idea, especially for our transplant ineligible patients who may have high-risk disease, in whom we're considering a proteasome inhibitor IMiD induction, to have that oral option. But we are getting, I'm personally getting a lot of pushback from insurance companies, despite the fact that we've tried.
So at this point, if I wanted Ninlaro on maintenance, I might be advised to see whatever clinical trial might exist for that, correct?
That is correct, sir.
And same question along the lines of daratumumab. Do you think there's going to be benefit in using daratumumab, Darzalex also called, in induction therapy, and in what combination? And with Dara, when you're using it, how are you finding patients managing the long infusion times or dealing with side effects? So kind of a 2-part question.
Sure. Daratumumab is being evaluated in upfront clinical trials in the first relapse as well as the upfront setting. In the upfront setting, there are 2 large randomized phase 3 trials that have fully accrued. One has fully accrued, and the other is going to be fully accrued in another 4 or 5 months. In the upfront setting, there's a trial that is comparing the combination of daratumumab with RD or Lendex, and comparing that with Lendex on its own. And this trial is for transplant ineligible folks. A very similar design trial was conducted or is being conducted in the first relapse setting, and that trial had finished accrual about a year and a half ago. It's similarly a daratumumab bortezomib dex versus bortezomib dex large phase 3 is being run in transplant ineligible newly diagnosed folks, as well as first relapse patients. In fact, you may have heard about the press release today that the combination of the trial in the first relapse setting, combining daratumumab with bortezomib and dexamethasone, came back with a positive result at the first interim analysis, and these data will be presented at the ASCO meeting in June 2016, which is very exciting, which means that the 3-drug combination for our first-line setting patients was able to give a positive result very, very early. So it was, the difference was so stark that they don't need a second interim analysis. So it's really exciting. The company is very mum about the results, and we're probably going to hear about this at ASCO in a couple of months. So for the transplant ineligible folks, data is moving forward as part of as an independent mechanism of action that can be partnered with proteasome inhibitors. For the transplant eligible folks, it's being combined with a 3-drug combination. I can share, some of my anecdotal experience with this combination in earlier lines of treatment. The depth of response is fairly robust, and as we know, that the deeper the response, the better the progression-free and survival outcomes, with therapies in myeloma. One of the major challenges with daratumumab has been the infusion time, especially the first infusion. My site has been involved with dara development for over 3 years. So it's, we know that we need, if patients are coming in for daratumumab, it's better to start the day early for their first dose. So generally patients are coming in between 8 and 9 a.m. and getting started on therapy so that they can finish on time within 6 or 7 hours if they don't have a reaction. But if they do have a reaction, it can make for a longer day, up to 8.5, 9 hours. And there have been some instances that other investigators have reported that they because they started late, they had to admit patients to finish the infusion. The way that the company is trying to mitigate that is by developing a subcutaneous infusion of daratumumab, and that phase 1 is accruing actively, and I have several patients on that study. The infusion time is about 30 minutes, and it's given sub-Q. The other thing that the company is developing is a more concentrated formulation of daratumumab so that the infusion can be given much quicker. The side effects that we're generally facing are low-grade side effects. So patients presenting, when they're 1 hour into their infusion, they're developing some itching, scratchy throat, runny nose, and giving Benadryl and a small dose of steroids can, mitigate those side effects. For the patients who develop grade 3 reactions where they're developing some shortness of breath or muscle spasms, breathing treatments and high doses of steroids or antihistamines may have to be given. But once that reaction is over and the patients are re-challenged with daratumumab, we don't see the side effect or the infusion reaction coming back. We think the reaction happens because the daratumumab, CD38 is expressed on many different cell types, including the respiratory epithelium. So, there may be, an inflammatory reaction in the respiratory epithelium the first time the patients are getting in, and that's why we get those side effects.
Are the infusion times being decreased at all in subsequent infusions?
Yes, so from the second infusion onward, the infusion time can be reduced to between 3 to 4 hours.
Thanks so much. It's always a pleasure talking with you.
Thank you, Jack.
Yeah, thanks, Jack. Cindy, are you online?
I'm online. Can you hear me?
Okay, Cindy, your questions?
Okay. The first question I have, Doc, is kind of a follow-up to what you were talking with Gary about the importance of seeing a myeloma specialist, and also the disparities that, there's some areas of the country where it's not really easy to get to that myeloma specialist, not like where I live in the Northeast. Has the idea of telemedicine for myeloma specialists ever been discussed? Having virtual consultations like through a Skype once your lab results or blood results are sent to a specialist? What do you think about something like that?
I think that is an awesome idea, and it would be, a great idea to develop regional myeloma tumor boards like that. We are developing a mechanism here in the Carolinas of making that available. That mechanism available. It hasn't been rolled out yet, but the idea is, you have a monthly teleconference where the community doctors can discuss their challenging or difficult cases with the myeloma experts at my program. I think we need to have more engagement like this with the outside communities, which are 3 or 4 hours away from the nearest myeloma center. I think that's a fantastic idea, Cindy.
Great. I would like to be able to use some of this technology that we have to service the areas of the country that are kind of underserved. My other question is that I saw something about a new formulation of melphalan has been recently approved. Can you talk a little bit about what that means and how is it different from the melphalan that we all received during our stem cell transplant?
Sure. So, the way that melphalan has been formulated previously, was for the longest time, I'm trying to recall the name of the new formulation, but nevertheless, the new formulation is a Captisol-enabled melphalan.
Evomela.
There you go. Thank you, Evomela. And so Evomela is Captisol-enabled. Captisol is the same chemical compound that is utilized to stabilize carfilzomib, for example. And the advantage of using Captisol is to stabilize melphalan and so that it doesn't degrade, and its PK or pharmacokinetics and pharmacodynamics are more stable. So the stability of the compound is extremely important. The other concern that we've had with the older formulation of melphalan, is the potential for erratic toxicities, not simply the GI toxicities, but the concern about cardiovascular side effects or toxicities. So, having this Captisol enabled melphalan helps mitigate some of those concerns. I think Dr. Harry out of Medical College of Wisconsin was the myeloma investigator who evaluated this new formulation for patients who are getting their stem cell transplant in the upfront setting as well as in the relapse setting, and found it to be as efficacious as standard melphalan, with some benefits from the side effect and tolerability perspective as well. So it doesn't it's not a major scientific advance, but certainly makes the melphalan delivery a little more stable.
Okay, that sounds good. We've talked a lot about...
one other thing on that same line is I understand that because it's reformulated, this melphalan, that you can give higher doses, and as a result, these higher doses will allow you to have a better outcome. Is that?
Yes. So, with the old formulation, the degradation, melphalan degrades fairly quickly once it's mixed in the bag. With the Captisol-enabled melphalan, that degradation issue, just like you said, will be overcome.
So that the melphalan will be available in your body for a longer period of time. Is that what that means?
No, that means that the dose that you calculated to give to your patient is the dose that will be delivered.
Oh, okay. That's what degradation is. Okay, that sounds good.
Yeah. So the chemotherapy is in the bag and it's breaking down even before the patient gets the dose.
Oh, I did not realize that. Okay, so the way that it's encapsulated or whatever that word is, it won't break down as fast, so when it gets delivered to your body, it's the dose that the doctor intended you to get.
In other words,
correct.
It kills your immune system better.
Okay.
And it can be technically given over a longer infusion, and you can infuse it slower than you would the regular propylene glycol containing melphalan.
Okay. I think I got it. I'll have to read a little bit more, but I think I got it. The other questions I had, we might have some new listeners here on the phone tonight, and we've been talking a lot about the high-risk myeloma. Can you just give us a brief understanding of what is high-risk multiple myeloma, about what percentage of people who are diagnosed with myeloma have these high-risk features, and what do you think are the most exciting clinical trials for this group of people?
All right. That is a very loaded question, and you've asked, I'll try to answer it efficiently.
Okay, I'm sorry.
No, not a problem. So, in a very simplistic way, high-risk myeloma is any myeloma that will result in a patient passing away within 2 years of diagnosis. Now, that is a very simplistic way of putting this, but I do want to highlight that within high-risk myeloma there are features that are patient-specific, and then there are features which are disease-specific that can cause you to have high-risk disease. You can have even easy-to-treat disease, but if you're not getting the right treatments because you have other comorbidities that will prevent you from getting treatments, that myeloma may be high risk for that particular patient, despite the fact that they don't have, nasty chromosome features or, poor risk by gene expression profiling. But high-risk myeloma by disease biology is a very, very broad group. There are many different ways in which we identify high risk. There are certain clinical features. There are patients who present with circulating myeloma cells in their bloodstream, which we call plasma cell leukemia. We know that kind of myeloma tends to be very aggressive. Then there are patients who have extramedullary disease, which means myeloma outside of the bone marrow. So patients presenting with myeloma collections in the liver or skin, even in the CNS or brain. Those patients tend to not do well with standard treatments and have a high risk of relapse. Then there are features on FISH testing, which is a special test done on the bone marrow aspirate sample, where we're looking for specific chromosome abnormalities. The translocations of chromosomes, such as chromosome translocation 1416 or 1420, are considered high risk. Translocation 414 is considered intermediate to high risk. There are certain abnormalities on fish like deletion of 17p, which is considered high risk. So these fish abnormalities, what they really mean is the patient's chances of disease relapsing after frontline therapy is high because the myeloma cells tend to be a little more aggressive and perhaps more resilient to the available treatments. There are other second-generation tests like gene expression profiling, which can identify patients at high risk of relapse within their first 2 years of diagnosis. All in all, about 20% or 2 out of 10 myeloma patients will have high-risk disease, and it will be, one of these features that will be able to identify high-risk disease. It is a very heterogeneous population of patients, and which, again, I said this earlier on the show that myeloma is not one disease; it's many different diseases. So the high-risk definition or the high-risk category also includes these different features. Does that answer your question, Cindy?
It does. Thank you so much. I think people will have a better understanding of that. I know what my other questions I'm just going to save for some other time because I see the listeners have some questions and we are out of time, and I just don't want to take too much of your time up. So thank you so much.
And Dr. Usmani, do you have a few more minutes to take listener calls?
Yes, sir.
Oh, okay, fantastic. Thank you so much. Priya, could you
Thank you, Gary.
bring on some of the
that was a wonderful
callers?
discussion. So, yes. We have a caller, a person calling in using 917-685-2380. Please ask your question.
Good afternoon, Dr. Usmani. This is Dana Holmes. How are you today?
Hey, Dana. How are you?
I'm good, thank you. I just wanted to interject that I, as a smoldering multiple myeloma patient, find that it's a very important message to deliver to patients to seek counsel with a myeloma specialist. And honestly, if you have the precursor diseases, don't wait until you find yourself in the myeloma world. Try to get to a specialist before and develop that rapport and that relationship. Because I really, really do think that that's critical for a smoldering patient for a lot of reasons, to get the right diagnosis, to get the right evaluation, and the proper monitoring during that smoldering time. So I appreciate you encouraging patients to do that as well. I have a question for you about Darzalex. I created a Facebook group, actually, for Darzalex patients, not only anybody who's using it, but anybody who's interested in it. And we've had a lot of interesting discussions and conversations and information sharing. It's really been very, very helpful for patients, and especially new ones that are heading into the infusions. And, some of these discussions are also uncovering that people are already getting it in different under different situations that are probably off-label at this point. So it's curious to me to see that already happening. And I realize that from a clinical standpoint, people do need this drug, but I think from a data standpoint that you tend to lose some of the, the data when this happens. So it's a, that double-sided coin. And I wanted to find out from you your thoughts about using Darzalex after a stem cell transplant, like in a maintenance setting.
I think there's music in the background.
Sorry, that's my phone.
Not a problem, Gary. I don't think that's a good idea. Personally, especially in absence of data, I don't think that is a very good idea to utilize daratumumab in the maintenance setting. and it's not that we won't see any clinical activity, but it's again the principle that you need to have some data to support what you're doing, and if you don't go picking therapies for patients in settings where it hasn't been really examined, because you won't know how to gauge the outcome. So the maintenance setting in a post-transplant situation, I'm not so sure. I mean, it's a good question to ask in a clinical trial, but to do it off-label, it is going to be fiscally difficult, and especially in absence of data, perhaps not the right decision.
Good. I'm thankful that you mentioned that and clarified that, because I think it's an important message to send out to folks. But again, I don't know if it'll do anything, but just as long as people are aware of that. I have a member in my smoldering group who transitioned to multiple myeloma, and she had her stem cell transplant with Dr. Harry, and he's developed a trial, or someone did, whatever it is. There is a trial that he's now introducing a checkpoint inhibitor after the stem cell transplant. So he's actually capturing that important data to be able to share amongst the community. So that's really just so critical, I think, as a patient also to do it the right way. Dr. Usmani, what is your thought about 2 weeks ago, Janssen announced that they're going to be combining daratumumab with a checkpoint inhibitor, something called, and boy, is this a mouthful, atezolizumab. It's basically a checkpoint inhibitor. It's an anti-PD-L1, and they're combining that in a study, and it's a phase 1. What are your thoughts about combining a monoclonal antibody and a checkpoint inhibitor?
I think there is, we've talked to Janssen and several drug companies who have checkpoint inhibitors, about that possibility, and I'm really excited about that clinical trial. I can also tell you that there are other clinical trials with similar concepts that will be coming down the pike. So this is not the only checkpoint inhibitor plus anti-CD38 monoclonal antibody clinical trial that is going to be run. There are others coming down the road as well, and the concept is really exciting, and I'm looking forward to it.
Do you see it moving into the smoldering patient population for clinical trials? Because that's honestly, that's like my dream cocktail at this point.
That is quite possible, but it may not happen until either later this year or early next year.
Well, I'll hold on to my smoldering shoe until then, Dr. Usmani, and when you open that trial, know that I'll be at your doorstep. Good. Listen, thank you so very much for your time. You're always so receptive, and it's just so incredibly great for patients to be able to communicate directly with myeloma specialists such as yourself, and I appreciate what you do for the myeloma community.
You're welcome.
Thank you, Dana. Dr. Usmani, we just like almost 10 minutes over time. I'll just ask you one more question, which has been sent in by, and we can wrap up. Question is, how is the scientific community tackling the increased adverse events burden, which is a part and parcel of combination therapies?
We're trying to develop therapies that have less adverse events. That I've tried to highlight the advantage with monoclonal antibodies and their safety profile. The fact that ixazomib being an oral agent appears to have less neurologic side effects than bortezomib, so it is an advance from a safety standpoint. the main idea is develop therapies that have less of an adverse event burden, and B, identify those adverse events early so that you can dose reduce and mitigate the side effects. I think those are the two key elements that we have to work on.
Thank you, Doctor. Thank you, Doctor, for extra time too. I think it was amazing discussion, great learning, and great listening to. Gary, Jack, and Cindy, as always, thank you for your support. And today's talk, the listeners will be made available on CureTalk's website along with its transcript. You can visit curetalks.com for details of upcoming talks. And thanks a lot. Have a good day.
You're welcome.
Thank you. Thank you, Doctor.
Thank you, Priya, Gary, Cindy, and Jack.